Tibabu, and I'm your host for the Going Digital Behavioral Health Tech Conference. I'm so excited to have this amazing panel of addiction tech experts and behavioral health leaders at health plans. So ladies, if you want to go ahead and introduce yourself real quick, Lisa, Megan, and Stephanie in that order, then we can get started.
Sure, thanks so much for organizing this awesome event, and really glad to be here. So I'm Lisa McLaughlin. I'm the co-CEO and co-founder of Work at Health, and I'm a clinical social worker and information scientist by training.
Hey everyone, I'm Megan Helke. I'm a senior product strategist, and I work for Premera Blue Cross, located just outside Seattle.
Yes, thanks so much. It's great to be with you all. I'm Stephanie Pape, the founder and CEO of Boulder Care.
Fabulous. Well, both Boulder Care and Work It, you both have partnerships with Premera, and I'm so excited to talk about how you are transforming digital addiction care for their members. So I'm going to ask a couple questions, but everyone feel free to weigh in as you'd like. I'm going to go ahead and start with Lisa. So addiction care has sometimes gotten a bit of a bad rap. How is digital treatment changing this?
That's a great question. And for those of you who've seen the skits on The Late Show and other programs, we know that there's incredibly rogue players in the space. So there's companies that have been charging millions of dollars just for drug testing, or offering horse therapy, or all sorts of weird faux treatments for hundreds of years, literally. So I think one of the things that digital treatment has brought to the space is it's broadened the tent away from this basic study abroad model where you go away to a center for an exorbitant amount of money and receive some kind of treatment, to a model that's much more transparent and clear what you're getting, and what you see is what you get. And that has been incredibly healthy for the space. We are moving away from like bloated costs and really vague offerings to clarity and precision. And I think that that increases trust among consumers, especially for consumers that have always had privacy concerns. Confidentiality and privacy are huge when you're getting addiction treatment. And I think digital offers that avenue, which helps legitimize your choice in seeking that treatment, instead of it seeming like a punitive thing where you're being sent away like a carrot, or either by a carrot or a stick.
Exactly. Yep. And then even more broadly, it sounds like even digital care can sometimes get a bit of a bad rap. Megan or anyone else, do you have any insight onto that?
Yeah, I think it's not even a bad rap. It's more just fear of the unknown. It's so different than how any of us grew up, thinking about how you seek and receive medical treatment. And so COVID has really been a catalyst to change that. For example, there's just so much more awareness and experience now with digital care. At Premera, which is located just outside Seattle, so it's a real hotspot. It was a hotspot for COVID. We saw our virtual care visits increase between February and the end of April by 95%. And so it just shows that you now have more awareness, more experience with digital care. And so I think that's going to continue to kind of reduce that or remove that stigma. And I don't think that awareness is going to go away either.
Yeah, exactly. But, with all this virtual talk, it's important to remember that, healthcare is local. So Stephanie, with healthcare being local, as a virtual provider, how do you embed in communities across different states?
It's a great question. Maybe also just react quickly to what Lisa and Megan have said as well, because I couldn't agree more. And I think all of us have been drawn to this space because the treatment industry has been broken in so many places. And the misconceptions, the stigma, all of these things that Lisa said have sent people away and expected a cure in 28 days without having, disparagement for any type of treatment that works well for people. Not one thing works well for everyone. And so when we adopt digital health or technology, I think in addiction, it's just useful to consider why we've done that and what problems we're actually trying to solve. So when you think about addiction treatment as pretty different from other types of medicine where you may get in-person care, there's not options for most communities across our country today. And for those that do have options for outpatient treatment, if you've ever been to a methadone clinic, often the experience is nothing like a normal doctor's office. This is on security. Your cell phone is taken at the door. People are lining up at 5:30 in the morning, sometimes daily, in order to get medication they need to thrive. And so technology solves for so many of these things with accessibility, privacy, and scalability, which I think we all know is so critical when the problem is reaching millions of people and so many barriers have held back treatment and its accessibility for so long. So I think considering the differences in addiction treatment, and then of course the local aspect to your question also being really important. And I think we've tried to do that at Boulder by integrating in every community we serve. In Alaska, for example, where we're now treating Premera members, we've got a medical director and a handful of amazing peer recovery coaches, all in Anchorage, Juneau, Fairbanks. They intimately know all of the resources available locally. We've given testimony to the medical board. We work really hard to understand the healthcare delivery systems so we can get people into primary care if they need it. So it's challenging, but I think as a digital provider, it's important also to recognize that each person you care for and the context and the environment where they live really impacts their recovery.
Yes, absolutely. So Lisa, another one for you. How do we build an ecosystem that is truly based on patient-led design?
Yeah, we started our whole company based on this concept that there was a huge gap in addiction treatment where patients weren't at the center of care. And that's why we lost 70,000 people in 2017, because there was such a lack of understanding of the disease of addiction itself and why people were using, as well as what works in terms of recovery. So even thinking about local integration, thinking of your last question, examples like that we've encountered as people who came to this field with a lens of abstinence-based recovery and entered this space thinking the only way to get sober is through AA and a relationship with a higher power, as most people have done for the past 20 years. And then learning as we went along that the science was so strong in support of medication-assisted treatment. I think that gives us as founders of Work at Health an incredible lens and ability to understand stakeholders on the ground and the perspective that they're coming from, and be able to work within past models and do the translational communication that you need to do to be able to raise the comfort level around psychiatry, raise the comfort level around taking medication, and make those things more acceptable in the recovery community. Because historically, what we've had is all or nothing model. So we've had individuals that either they get on the wagon, they say, I'm Lisa, I'm an alcoholic, I'm here to stay, or nothing. And all of the people in the middle that really didn't fit that paradigm, 40 of my close friends and family passed away because they just couldn't fit the paradigm. And they found themselves in emergency rooms for their fourth relapse, texting people and afraid to call friends in the local community because they're actually stigmatized from others in the local recovery community. So it's complex and it's fraught to actually integrate with local community players on the ground, because not all of them are operating from the science. And there's about a 20-year research to practice divide in addiction medicine that we're bumping up against. So it's incredibly important to have advocates, stakeholders that understand all those perspectives so that we don't come in top down with a heavy hand and say, we're doing this with medication, whatever you're doing with peer-led groups, that's kind of passe, because that works for some people and other methods work for others. And I think patient-led design enables all of the voices to be at the table that are impacted by the disease. And there's a saying in all kind of ableism-focused communities that is like nothing for us without us. And it's incredibly important. As someone who's been in recovery and has seen both the criminalization of my condition, as well as all kinds of fraudulent practices, following people into bathrooms as if they were criminals, forcing them to send them your urine in the mail because you're distrusted for taking a screen. We don't typically follow diabetics down the street and force them to do insulin tests from like on a miscellaneous drop of a dime, randomized, because that's cruel and it's unkind. And I think when you have patients at the table, they take those things that the medical community puts out in good faith and says, we need this quantitative data, and they say, hey, you're missing a lens, you're missing a perspective, and it's an important one. It's the human one. And I think we all need to keep that front and center.
I'm so glad you shed so much light on that. Absolutely. And I guess with that, for both of you, Stephanie and Lisa, just that responsibility and opportunity to make a difference in the space. Maybe start with Stephanie. What is the importance of having capabilities to address co-occurring addictions?
Well, first of all, well said, Lisa. I mean, patient-led design and a care team that really understands the unique attributes of the people that we're serving. It was obvious, but in our industry, it's not been that way. And to be able to give people multiple paths. So for some, maybe it is that 12-step, it works if you work it, and the culture that Lisa described. For others, maybe medication on its own is sufficient to care with all symptoms and symptoms so they can get back to work and school or family according to them. So we all really advocate for not just one way, but evidence-based ways. I'm so sorry, I even just got off on my soapbox and forgot the question that you just asked. We're all really passionate.
Yeah, exactly. Co-occurring addictions, how to address them.
Yeah. So polysubstance use is a really common experience as well. And in our panel, I believe 40% of the patients with opioid use disorder also have alcohol use disorder as a secondary diagnosis. So to really, again, understand everything that person's going through, their clinical experience, we've got clinicians with largely primary care backgrounds who are really trained to see everything that someone is experiencing, medical and behavioral, and find the right support for them, either through Uber or through one of our partners. With addiction medicine training, they really can also weigh in on some of these important aspects of medication in the brain condition. And to also have peer recovery coaches, again, certified and able to help with the non-clinical aspects of care. Maybe finding local support groups for alcohol use disorder, finding a center if someone needs in-person care, to keep them safe, or the ability to not just look at one point of a person's journey, one condition, one day, but really what their goals are over time. And reducing substance use if that's their goal, eliminating substance use, but never requiring that someone, make choices that aren't what they see as their successful path in recovery. So that's another issue I think in our industry is, some centers saying if you aren't willing to give up nicotine or alcohol, you can't stay here for your heroin addiction, and that can be obviously really harmful when heroin is one of the most dangerous drugs of all the other substances. So that's
Yeah, and I would add to that, from Promera's perspective, we do know how common it is for the people with addictions. They're often struggling with mental health conditions, so co-occurring conditions, not just co-occurring addictions. So often of mental health and even co-occurring chronic conditions, so dealing with diabetes or hypertension as well. So being able to help our members address their addiction, we view that as a path to also being able to help them address other co-occurring conditions they have. So really trying to solve for that whole person health situation, not just one condition, in a silo.
That's a great point. I'll weigh in on that. In terms of our patient population, 80% of our patients are not integrated into primary care. So they come to us specifically from consumer search by and large, and many of them are very distrusting of the broader medical system because of the stigma and because they fear the confessional model that historically has been required to talk to your primary care physician about something like an addiction. And because addiction medicine has been so specialized that primary care doctors are getting trained now, but are often still uncomfortable delivering such care on the ground. So for us, the main things we focus on with co-occurring disorders are, number one, co-occurring addictions, because to the point of the other speakers, no addiction is a single substance addiction. Polysubstance addiction is the only type of addiction that there is. I've never met anyone in my life who has not experimented with multiple substances as part of their addiction journey. So in order to deliver good substance use care, you really have to treat every single underlying addictive behavior that a person has, because we know that 50% of those underlying co-occurring conditions lead to relapse. So if you have an underlying gambling use disorder, if you have an underlying sex and love-based addiction, those things can lead to risky behaviors that then lead you back into your core primary addiction. And so historically, we've had these kind of one-track big groupings of addiction treatments, which haven't worked. Just the same way that, to Megan's point, we haven't had whole person care across the whole medical system. We want to move back towards a whole body, not like these separate different parts of a person being treated in isolation, because it's a terrible non-human centered way to do medicine. And then I would say the other co-occurring element that we deal with, a large portion of our population has hepatitis C and is dealing with pregnancy, and pregnancy is their primary moment of change, kind of instigating factor for seeking care. And so we have a ton of modules related to those conditions because we see them most prominently, and we know that those are incredibly vulnerable conditions that are both incredibly costly to the health system if not treated, and incredibly dangerous for the person experiencing them over the life course. And so what we find is that by and large, we are the primary care provider for the patients that we seek. And we do warm handoffs, but we take a unique approach to this, and that trust has to be built. So we make sure that everyone we're handing off into is addiction savvy, is a harm reduction bent, understands modern addiction science, and we curate lists of providers that fit that criteria. Because if we're sending an individual back into a stigmatizing environment, even if it's a handoff into a referral network, we could be sending them backwards as opposed to forwards. So it's really important to be full stack and to touch the person in every care dimension with an addiction-friendly service.
That's so true. As people are cycling between emergency department, hospitals, treatment centers, and the fragmentation is really detrimental, I think, to all of the patients that we serve. But to be able to facilitate referrals that, again, follow the patient everywhere they go. So we say, instead of warm handoff, sometimes we never let go of someone's hand. And that's really, I think, as just how the health system should be. Being someone's home when you're someone that they've built trust with is a goal that all of our clinicians really aspire to. So to be more integrated in medical and behavioral health and across the entire ecosystem, that's how we assure that people are actually getting that whole person treatment we've been talking about. And working with Premera, it's really been remarkable in actually getting to define outcomes that reward clinicians for doing that. So instead of saying, for your specialty, here's the outcome and here's the billing code, we've been really having rich discussions around driving overall outcomes like patient satisfaction, overall health, things like hepatitis C or HIV that are common with shared needle use or pregnancy, other conditions that addiction or substance use can sometimes exacerbate. And when we're all focused on driving outcomes and accountable for those, it actually rewards clinicians to collaborate and focus on all of these different aspects of the individual in ways that our traditional healthcare system hasn't historically been very good at doing.
Right, absolutely, couldn't agree more. Now, Megan, Premera being so cutting edge and having a lot of great partnerships already, I have to ask, why is there a need specifically for substance use disorder telemedicine or digital providers when plans already work with groups like Doctor on Demand or Teladoc?
Mm-hmm. This kind of builds, I think, from the prior conversation we just had. And when I think of behavioral health, I think of it as the umbrella term, right? And under it, we have mental health, like anxiety and depression, and then we have substance use disorder. And so we have members who have needs across that whole spectrum of behavioral health. And maybe, for both mental health and substance use disorder, or just one or the other. So it's very important to us to have solutions in place, virtual care solutions that meet those members' needs wherever they are. So we do use Doctor on Demand, their mental health services, Teladoc, their mental health services, but we felt that there was a gap in the substance use disorder area. And that's when we started partnering with Boulder and with Work It to meet the alcohol and opioid use and other disorders as well.
Fabulous. And speaking with collaborations, I'll start with Stephanie. Can you talk a little bit more about how you collaborate with other providers on the healthcare continuum to really coordinate care?
Yeah, well, I think as has been said, there is a very rightful distrust often with people who come in the door to Boulder, the proverbial door, of the healthcare system. When, emergency departments, primary care have sort of rejected the difficult specialty of addiction medicine and substance use. People are stigmatized as, again, in almost like a criminal justice approach rather than a public health one, despite acknowledging that this is a medical condition. So for us, we try to, again, really address all of the different medical and behavioral things that somebody may need, as well as their life goals. Our peers work with people on things like enrolling in school, getting a driver's license, finding employment. And so we work with largely referral sources with our partners in bringing us people who may not otherwise have a place that they can call home. So the legal system, we have parole officers who call us and help us coordinate when someone's coming out of incarceration, which is a really heightened time for overdose risk. And often people don't even have their health insurance because there is a suspension after their release. We work with emergency departments and sometimes even do a shared visit. So we have a co-visit for clinicians in person with someone who wants to, again, do that handoff. And while very, very respectful of patient privacy, they don't want us to share with other providers. We found most do, and they are able to kind of have our support in finding other resources and providers who share our clinical philosophy in really patient-centered care.
Awesome. So this topic of patient privacy and bringing other stakeholders like law enforcement. Maybe Lisa, if you want to start with this one, how do we build trust with patients with substance use disorders as healthcare providers?
I think it starts with transparency. So patients need to know what data you're collecting about them, who you're sharing it with, and why. Patients need to be informed that you're searching in opioid prescribing databases to make sure they're not receiving prescriptions from other providers. Otherwise, you're just creepy. So I think everything that we do in a handoff environment needs to be incredibly buttoned up from a technology perspective, because there's incredible vulnerabilities there, and we're seeing increasingly numerous hacks across numerous EHRs into patient data. And so especially in this space where you can lose your job for having an addiction that's documented, it's really important that we have that almost Swiss banking type of protocol in place. And so we think that's the number one thing. And then I think beyond that, ensuring that patients know, that you are their number one advocate is another key thing. Because I think we have hesitated to get involved with jails, to get involved with incarceration environments and certain other types of entry point into the addiction care space, because there has been such a long history of misuse of information in that space, and patients actually going back to jail because someone in AA said that they didn't go to the right meetings when that person's not a medical professional. There's been a lot of blending between community-based services and law enforcement that's fraught. And so we try to tread that area very carefully, because I know that there's been a lot of abuse that's occurred there that we need to move away from.
Right, there's so many core experiences that people come to us with, that it's really on us as providers to show them that we're different and build that trust and to earn it. So we'll have people, it's in small ways, I think, over time, but we'll have people say things like, well, I'm not going to text you if I feel like I want to use and return to use, because you're just going to not to. And to have one of our peers with lived experience say, no, I'm not. I'm going to make sure you have Narcan. It's something we send our participants, and that you're safe. And over time, harm reduction approaches and that philosophy, I think, started to reveal truly in action, not just words that were different. And we really do care about you, whether or not you use substances. And we also, as a medical group, try really hard to focus on language that's destigmatizing, both with the people we care for and with each other. We don't talk about, for example, compliance, and to say this patient wasn't compliant with the treatment plan implies that somehow that person did something wrong, when really, again, it's on us to rethink the strategy and give them what they need. We're delivering services to them, and their goals are our goals.
Really great insights into how many more complexities there are to serve this audience. Well, I'd be remiss if I didn't ask all of you, starting with Megan, what opportunities and challenges has coronavirus provided for this market, for a partnership like the ones you have? Any insight into that?
Yeah, I would say the challenges of COVID have produced a lot of opportunities to provide services to our members that we had planned on providing, and it's expedited our delivery of those services. I think, for example, like I mentioned, we're based out of Seattle, so Premera acted quickly and early on during the crisis to put some solutions in place for members. And one of them was by mid-March, we knew we wanted to expand digital care or virtual care access to our members. So on March 25th, we rolled out what we internally referred to as like phase 1 of our virtual care expansion. And it had two components. One is we added some additional virtual care providers focused on primary and urgent care. And then we also waived member cost shares for all virtual care. And then before we even had that launched, we started talking internally about the need to have a behavioral health expansion as well, because we all know that on the heels of COVID is our discussions and issues around behavioral health. And that's when we, by mid-April, we had launched our phase 2 on behavioral health. And the reason, I think the reason we were able to do that and meet that challenge was 3 reasons. One is we had strong leadership approval and support for this, beyond just the green light, like go and do this. It was the allocation of resources, the manpower, the hours that it took to put this in place so quickly. And leadership never flinched. Like, we were committed to making it happen. And the second thing was we had a pretty good foundation already as far as digital care. We had Talkspace in place for mental health care. We had Teladoc available to many of our members for mental health care as well. And then I think the third, like the linchpin of all of it, was we had a behavioral health strategy in place. We built it the end of last year. We had our plan. We had our roadmap for 2020, and COVID expedited it. So we had plans to roll out Boulder Care across our broader book of business in 2020. They were in Alaska for us, and we were going to roll them into Washington and make them available to our national accounts later in the year. But we obviously did that much quicker. We knew that we wanted to provide digital alcohol use disorder treatment as well. We had talked to Workit, I think, in early March. So we knew that was on our roadmap, and we were able to, I think we signed a contract with you guys in like a week. I mean, it was like the world record of provider contracting. It was huge lift by so many people. So again, these were all things we had on our roadmap, and we did them quickly. So I would say COVID presented this challenge that we turned into an opportunity to deliver these services and make them available to our members quicker. These are long-term solutions we wanted in place, and we were able to get them in place quicker, and we'll continue to be able to deliver these through the whole COVID crisis, the recovery, and the long term for our members. So COVID's been a huge challenge, but I think it's provided some pretty awesome opportunities for Premera, for our members, and working with our partners like Boulder and Workit.
We are so grateful for the contracting process and the leadership at Premera for pushing us through at a time like this, especially with the copays. That's legendary for people with substance use disorders, especially who are losing jobs, to receive this immediate access to care where they don't have to worry about the copay at all during the most stressful event of their life oftentimes. So for us with COVID, we have now over 10,500 patients on the platform. So we're producing some of the most compelling, important data in addiction science about predictively what people need in digital care, how to best deliver digital care, and how to understand where it's working best. And with COVID, we found that over 4,000 patients were texting, chatting, talking to their care providers about COVID. So we were very quickly able to assess what was going on with patients, assess the big barriers to care, and also learn a lot about, to Megan's point, the wonderful opportunities that lie in this terrible situation. Like, we found that blood pressures at visit 1 for patients quantitatively dropped significantly, taking their first visit from home instead of in the clinic. And we would have never have known that without this situation, where we were forced into a situation where visits were automatically from home. And I think seeing those trends and deeply understanding the social isolation that people with addictions have experienced has been a real silver lining to COVID. And we're grateful to have partners that really understand that and are forward thinking about delivering addiction care in a new era, in an era that's like immediately on demand and accessible and there for you when you need it, wherever you're starting from.
That's right. Having a progressive partner with the expertise and resources like Premera, kind of coupled with startups and our commitment to innovation, I think that's just a really powerful agent for change, and can't wait to see where that goes the rest of this year, particularly during this expansion where there is no out-of-pocket cost to members, which is critical and such an amazing opportunity for us. So opioid prescribing specifically has seen a lot of changes during COVID. As a result of the emergency declaration, there have been relaxed restrictions on prescribing and just opening up accessibility to treatment, including letting people have easier access to telehealth by enrolling at home. So one of our patients actually enrolled with us in a closet while sheltered in place with 7 people, and with one-word answers, total privacy, was able to get on and start treatment with us. Another emergency department worried that they were going to become infected with this virus because they were there for their opioid use, and it really sparked a motivation in them to want to change. So sometimes having people nudged a bit closer toward treatment and those barriers coming down, we just really hope that if we work hard, we'll be able to offset what we know is a public health emergency that always disproportionately affects the most vulnerable and exposes the cracks in our healthcare system. So it's kind of an epidemic within a pandemic, and silver lining, I think, is the perfect way to describe it. Let's hope that we can do things that should have been commonplace before COVID, and expanding access to addiction treatment and taking down some of these regulatory barriers.
Yes, absolutely. Well, I must say, I wish we had like at least 3 more hours. Such great insights. All of you are so inspiring in how you've put together this partnership and delivered services so quickly. Thank you so much for joining us, and excited for the rest of the attendees to network with you after. And again, really appreciate your time. Thank you, everyone.
Thank you. Bye, everyone.
Okay, Megan, you know how to, I'll edit this out, but.
I'm working on it.
Okay.
Okay, stop recording. Got it.
Got it.